Yeah, sir, fine, sir. Please
Okay.
do the slideshow, sir.
Yeah. So,
Fine.
so the things oro-myofunctional harmony is very important. Probably you can mention it little bit more in your essay type of questions, that how tongue and lip are so important while deciding how the jaws are going to grow. I'm going to discuss this in this presentation also. Prevention of deformation of dentition by various other factors, and majorly we will be discussing about space control in deciduous and mixed dentition. There's a particular note in this presentation which I want postgraduates to understand is, my aim is not to revise what we have already learned about preventive orthodontics in our BDS curriculum. My aim of this presentation is to give some, probably you can say, brownie points to postgraduates which they can write there in their papers or tell in their vivas to earn those extra marks and excel in their examination, and obviously help them in clinical practice therefore. So whichever slides has this mark, I'll be taking more time to discuss those things, and I might skip some slides which you can use for your use, because I know a video will be circulating among the postgraduates of this recorded session, and plus I'll be providing PDF of my presentation too, which you can use for later referencing. So maintenance of normal occlusion, let's briefly discuss what are the normal features of deciduous dentition, which we know is half round and a U-shaped dental arch is very important. We have to continuously see that how the shape of the dental arch, specifically the maxilla, is developing in growing kids. Almost the curve of speech should be absent. There should be very shallow intercuspal interdigitation, and this is a very important point while deciding your space management. I'll tell you why in later slides. Slight overjet and overbite is expected. Vertical inclination of incisors, we all know, gives a deeper bite, which is self-correcting. And obviously, the primary dentition ideally should be spaced, and obviously with no crowding. So this is how a well-spaced primary dentition looks like, and which has become a very rarity these days thanks to the modern diet and lifestyle. There should be generalized spacing. This is also called as primary spacing in the primary dentition. A very important study which I feel every postgraduate should know and mention in their papers wherever it is applicable. Study done by Lincoln in 1971 predicts that how the spacing in primary dentition will help you predicting the malocclusion or crowding in the permanent dentition. So if there is no crowding in the primary dentition, you can expect if there is crowding in primary dentition, you can expect 100% chances that the primary dentition will be crowded. If the crowding is up to 3 to 6 mm, there are 20% chances. And if there is over 6 mm of spacing between the primary dentition, there is no chance that permanent dentition would be crowded. So this is a very important study. Everyone should remember this year and author to mention in their papers. We all know how proximal caries leads to space loss. If you are getting a question on an entire essay question on various procedures under preventive orthodontics, this should be your first point. We are pediatric dentists, ECC is our domain, and we should consider preventing space loss through proximal caries. Under this is something you cannot cannot miss mentioning, is how does the different type of contact points affect or predicts or gives more predilection to caries. So this is an Oxis classification, very recent classification. Probably it will start coming in your textbooks sooner or later in newer editions as well. So do mention Kritika et al 2018 and mention this Oxis classification while you are discussing caries and proximal contacts, not only in preventive orthodontics, in all your other papers as well. Coming to occlusal equilibration, many times when the incisors and the canines are erupting, and when the canine erupt, they often get edge to edge. Now the child has two options, either to get into a positive overjet, but sometimes because of prematurities, the mandible starts shifting and the child develops a crossbite as seen in this image. So because it happens, it's an eruptive process. So it is very important to maintain occlusal equilibration when you do proximal restorations also, and remove functional prematurities, and that you can determine while asking the patient to close the mandible and note where exactly the shift is happening. So when you are mentioning about occlusal equilibration, mention about other things like enamel pearls, Labial maxillary incisor cingulum can also cause it, and this often leads to periodontal deterioration as an added complication too. Another important thing postgraduates should know and can mention in their papers is something called as planet direct tracks, which in a short form we call as PDT. You will find enough of research articles regarding this appliance, which can help in patients who have developed into a class 3. And this is nothing but a bite plane given in posteriors. It could be given in maxilla and or in the both the arches as well with particular kind of slopes. Though it is not a right platform to discuss how this PDT functions, but yes, in occlusal, if it has been caused, you can use PDT for to correct such kind of malocclusions in primary dentition. Disking, very important. If you are following it very closely, you are maintaining your record, you are seeing that this canine doesn't has enough space to erupt, we can always disc a primary molar, which is usually a E, to give that adequate space, because we all already know that because of that E space, the extra mm we will have, we can use that extra mm to let the canine erupt in place. Talking about supernumerary teeth, most of the time it is, if you are talking about preventive orthodontics, if it cause malocclusion, it's a different thing that it goes into the interceptive. But if you detect a supernumerary before it causes any malocclusion, it will come under preventive orthodontics, and that's how you differentiate, or you can write a first para differentiating between preventive and interceptive orthodontics. That supernumerary teeth is a very good example to discuss. So if the malocclusion has not been caused and you are treating a supernumerary, it falls under preventive orthodontics. AAPD guidelines, very important. They have mentioned how to deal with supernumerary teeth. It says should be removed before they cause displacement of other teeth. If it is a non-erupting primary mesodens, no treatment, because it might cause damage while you are trying to extract it surgically to the permanent incisor buds also. If it is erupted primary mesodens, let it shed. If it is erupted primary or permanent mesodens in a mixed dentition, extraction, which will lead to spontaneous correction. No braces is required. You just have to wait and watch for closure of that diastema or any other malocclusion which has caused except cross bites. And we have to make sure, if we are trying to do a surgical extraction, the adjacent teeth should have at least 2/3 of root formation to reduce the chances of damage while we do the surgical extraction of such teeth. Coming to retained primary teeth, the most common reason of a retention is absence of a permanent successor. The permanent tooth might fail to erupt is because maybe other reasons could be crowding, ankylosed primary teeth, presence of supernumerary, or other obstructions. So important thing, difference between primary retention and secondary retention. This can be asked in your vivas as well. So primary retention is when localized failure of eruption, but no other identified local or systemic involvement is there. And secondary retention is you can't explain why the tooth had come out of the oral mucosa but now has ceased to erupt. So unexplained cessation of further eruption after a tooth has penetrated the oral mucosa, and it usually you have to wait for 3 months to give diagnosis of retention. Mostly it happens in the posterior teeth. And again, if you want to mention ear and authors when to say it delays, you can mention Becker and Gron with the respective ears. It says if the tooth has formed 3/4 of root length and still not erupting, you can consider it as a retained primary molar. So treatment option is, if you want to retain it, we retain it to preserve the bone and soft tissue architecture. If you are doing an endodontic therapy of a retained primary molar with no permanent tooth bud below, better it is to seal it with MTA because it gives superior seal and doesn't resorb. If you want, we might in some cases have to retain and modify. Stainless steel crown will be a good option. Remember, implant placement should be delayed until the skeletal growth has ceased. Retention of a primary tooth at least until the late teens is therefore desirable. So if you want to extract it also, if possible, try to retain it so that it will help us to retain the bone level also and prepare a good future implant site. There could be an option of where you want to extract and there is already a crowding. It's a premolar extraction case. So you can extract a deciduous molar and close the space orthodontically. Ankylosed primary teeth, very common in primary dentition, and that too in mandibular arch. Treatment deciding factors is, do you have to decide which tooth it is, primary or permanent, how much ankylosis is there, what time you have diagnosed is, and where it is located. Again, AAPD guidelines in treating ankylosed primary teeth is succedaneous tooth if present, follow it closely, remove it at the time of normal exfoliation. Important point which you can mention is, which probably we might not have read in other places, is that some authors do suggests surgical luxation also of ankylosed permanent teeth with forced eruption. Coming to our topic, very close to my heart is oro-myofunctional balance. Some books discuss this thing under habits also, oral habits also, but yes, detecting and correcting those deleterious any kind of oral habit in growing teeth, growing dentition is very important to prevent future malocclusions. So this topic I would like to cover into 5 things. We have to see how the patient is swallowing, use of pacifier, then coming to mouth breathing, non-nutritive sucking, and tethered oral tissues. So I'm not going to discuss difference between bottle and breastfeed. We have all read it everywhere. Probably you can follow the slides and see that how breastfeeding is much more beneficial compared to bottle feeding. You can quote this author while describing the differences between breast and bottle feeding. This illustration is enough to tell, especially because those who are from first and second year post graduation. In adult swallow, we use muscles of mastication, but if the retained swallow is there, we are still putting the tongue between our teeth or in the gum pads, then it is called as retained swallow. Infantile swallow, when the child has to suck the milk from the mother's breast, he will have to put the tongue in between the gum pads, but this should not happen when the adult swallow has to be there. But if somehow this swallow gets retained, that's why we call retained infantile swallow, this can obviously lead to open bite cases. Remember, in adult swallow, we use muscle of mastications to swallow, while in infantile swallow, the whole of the face will suck. So infantile swallow will somehow look like this. But if somebody adult is still swallowing with moving the muscles of facial expression, this is not good, and we need to do some oro-myofunctional therapy to teach the correct swallow to such patients. Coming to pacifiers, very commonly it can be asked as a short note in your question paper also. Don't forget to mention Zimmer 2011. He has done a lot of work in pacifiers. It says that it helps to calm the children during stressful episodes, lull the children to sleep, and alleviate teething discomfort also. What AAP, it's American Association of Pediatrics, what they suggest is do not use it before 1 month if you are breastfeeding. It has to be stopped between age 2 to 4. Should not be coated with sweet, and it's obviously not a breastfeeding substitute. Adair 2003, very important. There is something called as sudden infant death syndrome. It is found that kids who are with pacifier, they do not suffer this sudden infant death syndrome. It also reduced breastfeeding chances, but however, it increases the risk of otitis media. Now, there are two schools of thoughts that pacifiers can cause more damage than non-nutritive sucker or not. Linder and Moder in 1989 said that it might cause more deleterious effect on canine width than digit sucking. However, I don't agree. I'll tell you because pacifier sucking is in very less magnitude, as pacifier is usually stopped a lot sooner than digit sucking. So usually you can expect much more damage with non-nutritive sucking, thumb sucking, finger sucking than compared to pacifier. Pacifier also are of two types. You can use a conventional pacifier or a functional pacifier. Some functional pacifier is something we should be advising to our patients, because there's one company called as NUK which gives you a functional pacifier. Few ERN authors to mention when you're discussing pacifiers in your questions. Understand this illustration. Now there are two types of functional pacifier. One is the Dentistar. This is the Dentistar type, and this is a normal NUK. You can see there is a slot for tongue to rest, and the child can learn where to place the tongue correctly. Very important as a oro-myofunctional thing. It teaches you where to place your tongue while sucking the pacifier. It is not there in conventional pacifiers. But problem with this pacifier is doesn't have space for the incisors, and this thing will lead to open bite. So to correct this, Dentistar came with this design, which helps in reducing the open bite chances. So counseling about non-nutritive sucking should be there. Pros and cons about pacifier with the parent should be discussed, and we should all advise the parents what is the right time to drop the pacifier habit. It's very important to prevent future malocclusions. Coming to labial frenum, lip tie. It's a it's a dilemma that what comes first, whether a frenum comes first or diastema. But this one thing I want to tell all postgraduates is you can expect a labial frenum to correct with growth on its own, but lingual frenum or tongue tie doesn't correct on its own anatomically, because as the jaws will grow, as the alveolar process will go, you might see changes in labial frenum. So don't hurry to cut labial frenum in your patients, though it is a functional diagnosis as well. You have to decide what functional issues the patient is facing, and yes, labial frenum can correct with growth. So the effects is it could lead to difficult tooth brushing, it could lead to recession and speech issues as well. When to treat? This is something difference between two school of thought is you should treat it before or after canine eruption. Test is if you are pulling the lip up and you're seeing a blanching on the incisor papilla, it's a thing that it shows that the fibers are going beyond the teeth, probably on the palatal surface, near the palatal surface, is causing the diastema. So this blanching tells that the fibers of the frenum are interfering and closing the diastema. However, in my experience, whenever I have just cut the labial frenum, the diastema has closed on its own. One school of thought says that if you cut it before the canine eruption, it will lead to scar tissue and it doesn't let the diastema close on its own. However, whatever limited number of cases I've done, I've not seen this scar tissue interfering in correction, self-correction of the diastema due to a low-lying labial frenum. L.A. Kotlow is a pioneer in TOTS, so you can quote his studies while discussing labial frenum or lingual frenum as well. Coming to tongue ties, most commonly in very young kids, the breastfeeding is the only problem. When the parents report to you that the child is not able to latch, not able to gain the birth weight, regain the birth weight, or the increase in birth weight is not as expected. So these kids need an evaluation about tongue tie by a pediatric dentist as well. In older kids, it causes certain different kinds of problem, but we as pediatric dentists should be very vigilant. We should not let the child suffer due to non-diagnosis of tongue tie. And if we diagnose the tongue tie and teach the tongue tie to be at the right spot, which is against the palate at rest, it will help maxilla growing really well. So classifications do mention this classification by again Dr. Kotlow, that how does the class 1, 2, 3 and 4, you can report it in your case papers also and discuss in your exams. So please remember, as I said, the normal positioning of tongue is against the palate, and that to the entire tongue, not just the tip. Now this is something called as mid tongue restriction, or previously called as posterior tongue tie. Also there's something called as anterior and posterior tongue tie. Now it could be a scenario that the child is able to lift the tongue tip only against the palate but not able to rest the other part of the tongue. Actual position should be this. So these are the cases which is we called as mid tongue restriction or posterior tongue tie, and they are relatively difficult to diagnose, but resting the tongue against the palate while the maxilla is forming is probably the most important thing to prevent future orthodontic problems. So that's how, if you rest the tongue against the palate, that's how you get a one very nice U-shaped maxilla. But in forming maxilla, if the tongue is not supporting the palate collapses. Either it reduces in size or it becomes like a V, and that's how overjet increase is you see. So if a V-shaped maxilla is seeing, if a maxilla is not U-shaped, the tongue has to be trained. And if you are seeing a V-shaped maxilla, you can make out that obviously this patient will have increased overjet. And that too, you have to be, as I said, very vigilant. Keep your records. As I'm showing you one of my case, beautiful U-shaped maxilla when the child reported to me with Caries problem, but as the child grew within 6 years, it became a very bad V-shaped maxilla requiring orthodontic treatment, suffering from sleep issues and all. So please be vigilant, keep taking your records. It is not like if the child has a good shaped maxilla at 4 will not have a bad shaped maxilla in 8. We have to be vigilant, keep calling them on important recall intervals. Maintaining a tooth shedding timetable is another very important thing which a pediatric dentist should follow, and you should be worried if there is a difference between a 3 months that the probably 5-1 has shed and 6-1 has not shed. So 3 months is the thing, and you should be vigilant, probably take an OPG age appropriate and then see what is going wrong where. So things which can upset a timetable is abnormal resorption pattern, retained deciduous fragments, supernumerary teeth, ankylosis, non-resolving bony crypt, soft tissue barrier, or maybe your big class 2, which is not letting the tooth to shed. Deeply locked or ectopic erupting permanent molars is again becoming very common because the maxilla are getting very shorter in size. The teeth are not getting their place to come in arch, and these kinds of ectopic eruption, permanent molar causing resorption of a primary E is very common, specifically in the upper arch. There it depends on the severity that how you are able to treat it. You can use an Halterman appliance, which you can use a D2 band and push. And if the you can see the occlusal surface, you can put a button and pull it out with a spring. There is something called as separators. Surgical uprightening can be done. Slingshot type appliances, I think we have made it in our postgraduate curriculum in preclinical, brass wire. And for very simple things, what we usually use is the separator, the orthodontic separator. Once you put it between the E and 6, the separator only has enough force to tilt the 6 little distally, and it gets corrected, often with just a simple orthodontic separator. So yeah, anticipating malocclusions becomes our job only, and we have to, as I said, we have to intervene as and when required. So one thing I want postgraduates to understand is if the primary canine has shed well before, especially maxillary primary canine or mandibular, maxillary primary canine sheds at age 12 or 13. If you are seeing a 8-year-old boy with no maxillary canine which has shed, this is a severe future orthodontic problem, and we should start intervening. Take OPG, see what things are going wrong, and probably look at the oro-myofunctional dysfunctions the child is suffering and work on it. So coming to space loss, there are various forces which are applied on the tooth which decides the positioning of the teeth. Finally, the teeth will stay where the muscular forces, occlusal forces, and eruptive forces are getting balanced. Whatever orthodontic force you have put, if you are not balancing the muscular and other forces, the tooth is not going to be stable at there. That's why a lot of orthodontic problems, when we treat with braces, then we advise lifetime retention to the patient. Lifetime retention is not something which is ideal. We should work on cracking the code that how we can make the tooth stay in the desired position without lifetime retention. And that is the answer, I think, lies on the oro-myofunctional imbalance the child is suffering from. These are the forces which you can mention, that how much tongue and lip forces put on the teeth, and the teeth incisors will stay where the tongue and the lip pressure will neutralize, that they will stay only at that place. Very important, a mark has come after long. This is something I want postgraduates to again discuss. We are almost halfway mark. Is everyone with me? Somebody can text in the, at least 10-15 people can text yes, 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 so that I know people are not sleeping. Good. So there's important thing which I want to discuss in this particular cases, which is called as mesial vector of force. We all know the teeth will shift mesially when the space loss will happen. E's are not going to shift distally if you have removed the D. They shift only mesially. So as I said, the various forces which are being placed on the teeth, there is a vector which comes, and this vector comes always mesially. So the tooth will always, molars will always move mesially. Anterior teeth might move distally because of secondary spacing or previously placed crowding, which I'll discuss in further slides. But remember, the mesial vector of force is there always. And one important consideration of mesial vector of force is how high the cusps are. I do not give a band and loop or a space maintaining appliance in a 4-year-old kid whom I have extracted D. I do not expect primary molars to shift mesially too much because they are flat. Now understand, a permanent molar has very higher cuspal inclines, and a primary molar will have very less cuspal inclines. So this less cuspal inclines leads to lesser mesial vector of force. So you will hardly see space loss in primary dentition or before the 6 has started erupting. But this particular case I want to show in 14 months, if you see how much space loss has happened. Now this space loss has happened because of two things. One thing is this canine has drifted distally. You can see here there is no space between lateral and canine, but here space has come. So one thing is the movement of canine has happened, and other thing is that E has also shifted mesially because this primary molar has unexpectedly very high cuspal inclines. So after this case, if I find very high cuspal inclines in a primary molar also, I give early space management, early space maintenance. So please understand the role of cuspal inclines in deciding the mesial vector of force. Another thing very important, probably the best thing in my entire presentation, and if you can mention it in your papers, in your viva, it will be great. There is something called as billiard ball analogy, which you will find. You can read it from the slides later on, and you can also, this is, I have read it in my second year BDS from oral pathology textbook by 10K. So yeah, do mention this. This tells you, along with mesial vector of force, why does anterior teeth again only move mesially? Because they don't have much cuspal inclines. So yeah, billiard ball analogy, and quote textbook by Dr. Tenkate. So factors to be considered is incidence of space loss, when which was the tooth involved, how much time it has elapsed since space loss. McDonald says the most space loss will happen in first 6 months, and it is obviously more rapid in the maxilla. And few studies to quote while discussing time elapsed in space loss. Amount of space closure is also important. It is always more in maxilla. Quote textbook by Dr. McDonald's. It is always more in maxilla. The space loss will always be more in maxilla. Few more studies to quote. Direction of space closure. Again, I would like to take some time in discussing this. Direction of space closure, we have to understand, it's a combination of three things: tipping, rotation, and translation. Now it depends on what kind of teeth we are talking about and how that particular teeth will move. Quote textbook by Dr. Moers while discussing this. There is very important Cornfield field theory, which says there are neutral areas in the jaw, and for these, that for maxilla the neutral area is in bicuspid and mandible is it almost mesial to 6. So uh, as per Cornfield field theory, the anterior teeth will move towards, every teeth will move towards the neutral area, anterior teeth will erupt distally, and posterior teeth will migrate forward. So yes, the maxillary molar, we have to understand is the maxillary molar always rotates on its palatal root. So if you are seeing a space loss in a maxillary molar, the maxillary molar will cause space loss like this, because this is the palatal root and it will move like this while causing space loss. If you are seeing a space loss patients in your OPD, you will realize that the maxillary molar, or in fact the maxillary primary molar has rotated like this while causing space loss, while a mandibular molar will mostly tip. The lingual tipping you will see. This is all because of the tripod arrangement of the roots of the upper molar. Stage of development is very important. If eruption is happening, you can expect more space loss. Again, as I said, eruption timing of permanent successor is also affected. If the primary molar is lost as 4 years, premolar gets delayed. If at 6 years, there is 6 months delay. And one clinical important point, as quoted by Dr. Fanning in 1962 also, the root formation level is not important that when the tooth will erupt. I have seen premolars erupting in 5 and 6 year old age patients as well, which had almost no root. I think it's more important point is how much the bone crypt is left, how much the healthy bone the tooth has to cross. Sometimes it happens is when you remove a severely decayed primary molar and the bone is all gone and the bone doesn't get time to heal itself, then it might happen the premolar might spurt through that not so well formed bone, and you might have a premolar in the oral cavity at age 5 or 6. So erupting time of permanent incisors, very common questions for examiners in viva. It says McDonald quotes 7 years, Pinkham quotes 8 years, that before 8 years it will be the time that it will take more time. After 8 years of age, if you are removing a primary molar after 8 years or 7 years, it will come early. Before 7 or 8 years, it will take more time to erupt. Very important, as I said, amount of bone covering the non-erupted teeth is very important. Very important Viva question, very commonly asked. It takes around 4 to 6 months for a premolar to travel through a 1 mm of healthy bone. Please note it. You have to mention in your papers, and probably will be asked in your banded loop chairside Viva as well. Abnormal oral musculature, I have already discussed. Non-nutritive tracking, strong mentally section which can affect. These are the few values which you can mention and illustrate in your papers. Available space is something which, if the tooth is a crowded dentition, you lose more space rapidly. If you have done all extraction due to proximal cases, it is possible that already the space has been lost. Already when the distal, there was a huge distal cavity in the primary molar and the E has already tilted in it, already the space loss is reduced. Interdigitation is again more important, as I have discussed. If the molars are in already a class 1 and you are thinking to give a space maintainers for lost first primary molar, very less likely the tooth is going to move, because the interdigitation will hold the molars. If they are in a flush terminal plane or edge to edge, then you can expect the molar to slide and cause space loss. There's some usually 4 erupts before age 7, but we have to be vigilant to understand there might be some cases where the 7 will erupt before the eruption of 4, and this will call even more space loss. So the 4 should be there to hold its space in case usually 7 erupts later than that, but you have to be vigilant and prepare that space for future 4 if 7 is erupting before 4. Congenitally absence of permanent teeth, or eruption of teeth is also there. You can, I think, yes, see this, in this upper E has over erupted and it is holding the molar back. So in such cases you do not need space maintenance. Upper E, the distal part of the crown of the upper E is holding the molar in its place. The molar is not going to shift ahead. In such cases, this is also happens in some of the cases, and such cases do not require space maintenance. So loss of D, whether to give a space maintainer in loss of D is very dicey and probably a very good postgraduate level question, and you should consider reading many articles on which have discussed loss of D. I'll be leaving few findings and articles in this, but loss of D is something a postgraduate should be very prepared to answer in your questions and probably in your vivas also. So state of eruption of 6 is very important while deciding the thing, as I said. Now, this is the same case I want to illustrate and make the concept understood by the postgraduates. See, I removed the D in 2018 till Jan 2020, almost 20 months. There was no space loss. Now the space loss will start happening because the 6 will erupt and it will push the E and E will go ahead. So there is no space loss in 2 years. Why? Because the molars were almost flat. If I would have rarely found a very high molar with high cuspal inclines, I would have expected a space loss here as well. So that's why I do not give space maintenance in a primary dentition. I give it just before the 6 is about to erupt. This is article in my post graduation time. This was a very frequently quoted article. So yeah, please go through this article and see what Dr. Padma Kumari has mentioned regarding loss of D in her research. Loss of E, when you lose E, it becomes much more dicey. We all know before eruption of 6 we have to give a distal shoe, and after then we can do after eruption of 6 we can do a regular space maintenance like TP, NP and band and loops. Important slide. Loss of E, just see how does the 6 moves. Path of eruption of 6 is very important for you to understand and plan space management. As I said, see, the upper molar is forming with his occlusal surface facing distally and buccally. Upper molars form in their birth stage with their occlusal face facing distally and buccally, and with the eruption they erupt like this. They probably meet a muscular resistance, which, because they are faced buccally, once they are erupting buccally, they meet muscular resistance and then they come into the arch. And how does the lower molar erupts? Lower molar is forming with their occlusal face mesially and with mesially tilted like this, and then they erupt like this. So understanding this movement is very important, especially deciding for your distal shoe design as well. So as I said, maxillary probably meets a muscular resistance and then they eventually get into the right path. Another illustrations in explaining the same thing. 6 and E will erupt with a similar path of eruption. Understanding this path of eruption is very important. I'll explain this in coming OPG. Lower 6 will take eruption guidance from the distal crown of E, but upper 6 doesn't need distal part of E to be in the right position because their path of eruption is different. In some cases, we might have to reduce or extract permanent sixes as well when they are have poor endodontic diagnosis or there is no crown to be saved. So in such cases, in loss of 6, we have option of removal, extraction of opposite 6, or auto transplantation as well. While you're mentioning loss of 6, there is a very important thing which you should mention is because maxillary molars as per Cornfield theory will move. So maxillary molars will always move in unison, while mandibular premolars you will find moving distally in separate ways. So important thing which I have even observed in my patients also, and very good thing to be mentioned and predict in your patients when you are extracting or you have lost 6 before eruption of 7. Few studies mentioning the same thing. See this is the thing. This is one of my case where I have extracted 1/6 with poor prognosis, and eventually see how 7 has come exactly in this place. It's just like that I have done some beautiful composite restoration on it. It's not a same tooth. I have extracted 6, waited, and see how 7 has taken place of this 6. Clinical assessment, while before you plan your space management is given by APD, you should follow, you can mention and quote this and put these points that how you will be clinically assess a case before deciding for a space management. There are mixed dentition analysis there, Moyer's, radiographic, Hickson, Oldfather, and Tanaka Johnson also. Because of lack of time, I'm not discussing these things. But yes, each of this or in a combined, this can be asked as a question also, mixed dentition analysis, which every postgraduate should know. So coming to space maintainers, few classification of space maintainers. Coming to start with removable space maintainers. Removable space maintainers is something which is very dicey in clinical practice because usually the kids do not cooperate for any removable appliance, at least in my practice. So but yeah, indications and all, you all parts and you all can write it easily, but just I want to discuss the contraindication of removable space maintenance is the patient is lacking cooperative ability, the mental age is below 2.5, acrylic allergy, or obviously in epileptic patient you cannot put anything loose in the oral cavity. Study by Hill et al. Suggesting that they gave only 4 removable four removable space maintenance in total of 226 space maintenance, and none was present after 6 months. A good study to be quoted when you are discussing removal space maintenance. However, Dr. Finn in his book says that generally speaking, most space maintenance can be accomplished by inserting removable passive space maintenance made of acrylic and wires. Yes, it is a beautiful space maintenance, is a functional also, but getting the cooperation out of the kid becomes difficult. Coming to band and loop, most common space maintainer, there is something called as long band and loop also when D and E together has to be extracted and your 6 has been erupted. Remember, you will give bilateral band and loop before eruption of lower incisors. You cannot give a lingual arch before all the permanent 4 incisors has got erupted. So lingual arch is contraindicated before eruption of 4 incisors. You have to manage that case with bilateral band and loops. Coming to very important, I was always asked in my post graduation that where you will rest the mesial part of the loop. So you have to quote few authors as given as mentioned in textbook by Dr. Shobha Tandon. The mesial end of the band and loop on the canine will rest usually below at the contact point, while another author suggests it should be at the contact point. So there is something called as primary spacing and secondary spacing as well. Primary spacing is the generalized spacing which I told, it's there inherently in the jaws, but as the child is growing, you will see some secondary spacing also happening. And the secondary spacing happens when the lateral incisor erupts. And once the lateral incisor erupts, it pushes the other primary teeth away and it causes some kind of spacing. So this is called as secondary spacing. Please remember, this could be asked difference between primary and secondary spacing. There are few modifications of band and loop. This one was modified by me and published also. We see there are various modifications with single arm of the band and loop. Every published work has done it for different reasons. I did it for reason because in this particular case, because it was a long standing loss, the probably D was has erupted more or the canine has moved and I could not place a bar. The occlusion was not allowing me to keep the palatal half of the loop. So I had to cut it and I did it in 2-3 cases. Then I realized it's a common thing and we went for publication. So yes, this is something you can mention in your papers. Another modifications are reverse bonded loop on one side given by Dr. Moyers and band and bar like this also. One more modification with single arm was this was given by Dr. Matthewson, where the 6 has erupted from bone but not through the gingival tissue. Mayonnaise space maintainer given in Dr. Graeber's book is something called as semi-functional, where they want to mimic a function by giving two close by wires so that patient can eat a little, given in textbook by Finn. There's something called as there's one publication by Dr. Nayak et al. In 2004. Where they have preformed and make the loops preformed, and then they have tried to fit the best loop in that particular case. The good point was when they welded it with the band, so no soldering step, so it was a single sitting thing. So you can quote this study, this by Dr. Nayak et al. 2004. Something which is new has come up and every practitioner is using nowadays. Our Indian company has come up with preform band and loops, where you and the similar using the similar concept, you can quote these articles as well. This makes the life so much easy. Only issue is that you have to be vigilant as the premolar won't erupt through these loops, so you have to remove it when the premolar is about to erupt. Coming to crown and loops, when your distal abutment is not healthy, band cannot stay, you might have to give a crown. One thing I want to tell postgraduates is there could be two things. You might have to solder the loop on the crown. Another way is you put a band over the crown and do it. I usually prefer band over the crown and give a crown and loop, or you can say band and loop over a crown. Another modification of single arm given by textbook by Dr. McDonald in crown and loop. Lingual arch, beautiful appliance, does so many things but little unstable. That's what I feel. So disadvantage is decalcification of the molars, and that's why you have to seal this margin between the band and the tooth, and that's how the one extended sealant technique, which I had skipped in before my slides before. Please mention that study, extended sealant technique, in which they have tried to close the gap between the band and the tooth by a flowing sealant in the space. Where to rest the arm of the lingual arch? Few authors, some suggest incisors at the 1 mm to 1 mm lingual to the loop should be 1 mm lingual to the posterior teeth, should meet the band at the mesiobuccal cusp. These are important design consideration because you were asked a lot of lingual arch questions, so probably you can draw a good diagram and discuss these things and quote Dr. Kapala 1985. The loop, where your wire is attaching to the band, it should be 1 mm lingual from the soft tissue to allow the posterior eruption of teeth, meet the band at the mesiobuccal cusp. Contact length should be 3 to 4 mm. You should have enough length to be soldered, and it should be lie in the middle third of the molar band away from the occlusion. You have to, very important, check whether your solder joint is coming in occlusion or not, because it often breaks if it is high in occlusion. Passivity, lingual arch is a passive appliance. You cannot force something into the tooth, it will cause tooth movement. It's a passivity. One thing people suggest is you can heat the wire and cause it passive. Easy way to test passivity is dental floss. Cross the dental floss between the teeth and between the teeth and the wire, and it should be passed very easily. Horse modification, because if you are writing question, you have to write about modification of the lingual arch also. Weldable. Then there was a Mershon type lingual arch, which made me to discuss the secondary spacing and intercanine width also, because if you are giving a thing like this, a ball end thing on the canines, it will not allow canines to distalize, which is very important. So you discussing increase in intercanine width is very important. This is the data. So while putting clasp on canines, you should be very careful whether the canine width has already increased or not. If the intercanine width is not increased, which happens with maxilla when the central incisors are erupting, and mandibular when lateral incisors are erupting. If the canine width has not increased, please do not hold the canines. And again, you can modify the band and loop also, because the loop, if you are designing it against the canine like this will not allow the canine to distalize. So there's something called as plain band and loops also, which you can mention in your papers. So space maintenance might cease to increase the intercanine arch width and length during the transition period between the primary and permanent. So as a postgraduate, as a specialist pediatric dentist, we should keep in mind this thing while planning our space management. Other modifications of lingual arch. Coming to Nance palatal arch, very beautiful appliance, very stable appliance. Again, people ask that how much away you should keep this acrylic button from the teeth. So it should be 1 to 2 mm away from the palatal part of your incisors. However, the problem is it will cause irritation to the mucosa, because wherever the palatal button is resting against. Again, one more quote you can do, where the palatal button should be 1 centimeter lingual to the lingual surface of incisors. Transpalatal arch, very beautiful appliance used for unilateral cases. Now, as a postgraduate, you should understand, can you give transpalatal arch in bilateral lost cases? Research about this, be prepared and write a good note, that whenever you get chance to write about transpalatal arch, that whether transpalatal arch can be given for bilateral cases or not. More you will read, more you will get excited that few authors suggest it can be given, few don't, because the school of thought which says that it can be given is, it says that because if you are holding both the molars, they will not rotate like this, because, and even if they rotate, they may easily tip hardly by 1 mm, which is very insignificant. So people who think that bilaterally, in bilateral loss cases, TPA can be given, this is their principle. There are modifications on transpalatal arch also, using this loop which can help with rotations and all. So few studies to quote in bilateral space maintainers. Distal shoe, very nice topic, very interesting topic. And distal two, we all know that how to classify this and what kind of loop we are using. We are using a Rocher type root now, which is a V shape, though we have now preforms distal shoes available as well, which have made the life so easier. Now I extract more ease after having a preformed distal shoe than before, when I had to make it custom made. However, contraindications for distal shoe, we all know, is lack of patient cooperation, few medical conditions, and the abutment is not enough to hold the shoe. Position of distal extension, very important. Please note it, very important for your clinical perspective also. When you are doing a distal shoe for the lower, the position of distal extension should be slightly lingual to the position over the crest, and it should be slightly facial while doing for the upper. Why? Because the path of eruption, which I have already explained it to you. It could not be too narrow, because otherwise the 6 will slip. See, in this case, the 6 has slipped, and then I have to immediately give it a reverse crown and loop for this case. So it should not be very narrow. You have to discuss the length also. The best way to compare the length is compare the radiograph with contralateral E. Because I have a preform space maintainer, I do preform, I extract the E and I decide the length like this, and it helps me really well. And then I don't see that, I do not worry that how long my distal extension should be. Depth, it should be 1 to 1.5 mm below the mesial marginal is. If you are keeping it too deep, it will eventually might start hitting the premolar as well. Few studies for distal shoe. Now this is again coming back to that path of eruption, and very important, deciding your distal shoe, distal extension placement. See carefully in this OPJs, the 6 is are about to erupt, but it is yet not touching the distal part of E. The lower molar is also about to erupt, but it is taking guidance from the distal part of E. So probably if one take home message in this 1 hour lecture you people can take home is this: upper 6 and lower 6 erupt differently. They have a different path of eruption and they have different guidance to be used. Epithelize, there is a study that because the intragingival extension gets epithelialized too. You can also mention about a metallic tattoo which was left in the gums and discussed in the textbook. There is something called as Gracia gordae appliance also, which is little bulky, and there could be some conditions where newer modifications can be used, like this distal guide. This is such a great appliance. Probably if I can get a lab support of this, I will start using such kind of appliances as well. So distal guide, this is not any intragingival thing. It is just mimicking the distal surface of E. And this study which they have mentioned, case series, they have very good success rate also. Probably this is also some design you can try, and very recent publication of 2022. There's something, another a case scenario could be there where you have to extract D's and E's together without the eruption of E. So there is something called as Proper's appliance with distal shoe modification as well, which can you can quote this and probably use in your clinical practice in such special scenarios. There could be a removable distal shoe space maintainer as well. We all have done this in preclinical exercises. Bonded space maintainers, whenever you are talking about fixed space maintainers, you have to include a note on bonded space maintainers, how confident you are with your bonding, with your composite. Only thing is, if it becomes loose, the chances of aspiration or ingestion are there. So I don't use it, but you have to mention in the theory part. Fiber reinforced composites are also there. In the end, soldering is something which can be asked in your viva, because you have to solder your band and loop in your exam. So remember, there are two type of solderings: investment and freehand. And usually we are not investing it like how prosthodontic people do for crown and for fabricating the metal crowns and all. We are doing freehand soldering. So if you are asked what kind of soldering you have to do, we have done freehand soldering. Some other articles, recent publications which you can quote about discussing your long questions in your preventive orthodontics. This you can take and note it down. Preventing OSA, obstructive sleep apnea in kids, is our duty. Remember, being pediatric dentists, we have to make our kids breathe well. If they don't breathe, they will gonna cause malocclusions, and leave out malocclusion, they're gonna be probably an apneic patients when they grow up, and this is going to affect their life a lot. So be vigilant about how your patient is breathing when he's growing. There's something called as Roma index also I came through while researching for this lecture. This is something again you can quote. This is the index which is used in 2 to 6 years of kids to predict future malocclusions. Survival rate of various fixed space maintainers. And they said the prefabricated band with custom made loop exhibited maximum success at 84%. Conventional was 73, and the bonded was just 45. So I think this study gives you an idea. Almost more than half of the bonded space maintainers are failing, and the custom mades are surviving better than conventional band and loops. To end with, I think I have, yeah. She is my guide, Dr. Rashmi Nayak. And don't finish or start my PPT without mentioning her name. She is my guide, Dr. Rashmi Nayak. I was her first full-time student in Manipal. Whatever I'm there today, I'm because of her. And all those postgraduates who are listening to it, just I want to share a one-to-one thing with you guys. There was not a single day where, you know, I don't want to use the word, because I was not happy with my guide. Hey, ma'am, why she's making me do so much work and all those things. And I was like, if the day had a 25th hour, I would have spent in library to do things which ma'am has told me to do today while I come back to department tomorrow. So it was that stressful, and I really thank ma'am to make my 3 years of postgraduates stressful, to make me work hard like anything. So postgraduates, if you are if your guide is telling you to work hard, it is for your own benefit. Please make sure your 3 years of post graduation life is not easy, because if you will struggle in if you will do if you'll struggle, if you will do good work, if you do what your guide says, you will work hard, your success after post graduation life will be much quicker. So thank you, Dr. Rashmi Nayak ma'am, for for helping me out becoming an average pediatric dentist. So this is my place where I belong to. Anybody who of you are coming to my city, Jaipur, please pay a visit. Mention that you have heard my lecture. I'll be happy to meet you, help you with any touristry guidance or any professional guidance if you need in pediatric dentistry. So thank you. This is our last question, which I want you two people to think over it and probably reply to me personally on my Instagram DM. See, both these cases need now extraction of primary canine. It's a retained primary canine and it's not letting the canine erupt in the right place. It's the same case, same patient on other side. Now I feel this is definitely interceptive orthodontics because the canine has already erupted buccally, but I am sure after extraction of this canine, this primary canine, this permanent canine is going to come in place. But do you feel this is if you extract this other primary canine to make this canine come in right place, is it preventive orthodontics or interceptive orthodontics? Thank you.
Thank you, Deepesh, for a wonderful lecture on
Thank
preventive
you.
orthodontics. A lot of questions are there from the audience. I think Dr. Imtiaz will take up the questions with you. Thank you.
Sure, sure, sir.
Thank you, sir. Thank you for your contribution. An excellent lecture. Hello.
Thank you. Yeah, I can hear you. Thank you.
Sir, before going to the students' question, I have a small question, sir. As you mentioned, I prefer for a band over a crown, band and loop over a crown. Sir, is there any modification for the luting cement, or we can use normal general
No,
luting
it
cement?
stays really well with luting GIC. Only thing is you have to wash both bands and the crown surface with hypo.
Right.
Because it's a single sitting thing, you are not sending it to the lab. So crown also you are doing on the same sitting, and you have a preformed band, so you are doing on the same sitting. So the saliva gets coated on the outer surface of the crown and in the inner surface of the band also. And whatever you do, air, water, that organic layer of saliva doesn't washes off. So my tip, even if it is for bonding a simple band, is please put it in hypo. Let the hypo dissolve that organic salivary proteins which is there on the band bonding surface of the crown or the band, and then cement it. It helps. It really helps.
Sure. Thank you, sir. There's a questions from the students, sir.
Yes.
When should we give transpalatal arch and band and loop in maxilla?
Transpalatal arch is for multiple unilateral loss. So if you are lost 5-4 and 5-5 after eruption of 1-6 and 2-6, I prefer transpalatal arch, because if I give a long band and loop, it might not be stable. So yeah, if you are asking between band and loop and transpalatal arch, unilateral multiple loss is the indication for transpalatal arch.
Yeah. Next question, sir. Explain the reasons to not give lingual arch before 4 incisors are erupted. Also, can you please give reference for the same?
Reference I'll share because I don't have handy reference. I'll definitely go back and give you the reference. But the reason I can tell you right now is because often we have seen that the mandibular permanent incisor erupts lingually to the permanent incisor often. Right. So if you have already given a lingual arch and then the permanent incisor has erupted lingually to the wire of the lingual arch, then you'll have to change the appliance, or it might interfere with the eruption also. So that's why before all the 4 lower incisor has got exchanged, you do not give lingual arch. It's a contraindication. You have to wait for 4 permanent incisors to erupt before considering it for lingual arch.
How does it affect the growth of the mandible, sir?
No, it doesn't affect the growth of the mandible. It interferes with the eruption of the.
Does it have any effect, sir?
No.
Lingual arch?
No.
Another question, sir. Another question is regarding the loop, sir. Why mesial end of the loop should be placed below contact area of canine or not at contact points?
See, I have just quoted various authors. In my practice, I check the occlusion. I might put it at contact. I might put it below the contact. It all depends where the opposite tooth is meeting my. I don't want to keep my loop in the occlusion. For your theory purpose, I have quoted two authors differently who are saying where to put the loop. But in my practice and clinically, logically also, you have to place the loop where it is not interfering in the occlusion.
Yeah, next is about the intercanine width, sir. They want another explanation for intercanine width.
See, intercanine width, the canine has to move distally and buccally, both maxilla and mandibular. The canines have to move like this. This will help in gaining the space for the future teeth. So the intercanine width in maxilla increases when central incisors are erupting, and in mandible it increases when lateral incisors are erupting. So you cannot hold those primary canines and let them move distally and buccally and interfere with increase in intercanine width. So it could be with your Bandel loop also. If you're making a loop, C loop like this and hugging the canine, it could interfere. So, or it could be your additional canine spurs also. So before the lateral incisor for the lower has erupted and central incisors for upper has erupted, do not interfere with the canines. Leave the canines free. And that this is the same fundamental why we are having straight loops for Bandel loop also. There are two kind of loops. There could be a curved loop or straight loop also. Straight loop allows the canine to slip. If you give a curved loop, it doesn't allow the canine to move distally to increase the intercanine width.
Distal shoe in case of maxilla, sir.
What?
There are asking, can distal shoe given in maxilla?
Yes, why not? If you have to give, you can give. I mentioned what the modification you have to do in the direction of the distal extension while in maxilla and mandible. You have to place it slightly buccally because the molar is coming from the buccal direction to in the occlusion.
Okay, sir. Thank you, sir. We will answer the remaining questions in personally by chat.
Yes. People can DM me on Instagram. I'll be happy to help.
Next slide, please.